did briefly touch base about side effects with these treatments. The most common side effect with these treatment is something we call cytokine release syndrome. The easiest way to think about this, if you've ever had a viral infection with fevers, feeling just blah, that is generally some of the symptoms that come along with cytokine release syndrome. It typically starts with what we will see an elevation of heart rate. Patients will have fever, and then subsequently they can develop low blood pressure or have trouble breathing. Now, we will grade the cytokine release syndrome based on the severity of these symptoms. The vast majority of patients in all these treatments will have majority grade 1 to 2 cytokine release syndrome, grade 1 just being a fever, grade 2 being either some shortness of breath or low blood pressure, but does not require any invasive clinical care, such as intensive care unit stays and things of that nature. Those typically associated with grade 3 and grade 4. The other side effect we typically see with this line of therapy, there's immune effector cell neurological syndrome, which we call ICANS. In this situation, this is typically manifested as confusion or some degradation of mental capacity in a short-term fashion. The good thing with the bispecific antibodies is that these rates are very low, especially compared to what we see with chimeric antigen receptor therapy, which has higher rates of ICANS and functions in a similar fashion. So for the most part, the biggest side effects are CRS. We do have some other symptoms such as low blood counts, infections, obviously because of the treatment does impact some normal immune cells as well. Fatigue is another common side effect in these situations. And specifically with epcoritamab, we will sometimes see some injection site reactions, which is generally warmth and redness in the area where the drug is injected. Both of these drugs have very similar rates of these side effects, especially CRS. Again, these range from 50 to 60% of patients. Again, the vast majority of these are grade 1 to grade 2, which are generally manageable, and these are all short-lived. And in the clinical trials, practically all of these events resolved in all the patients on treatment. Now, the biggest crux we have as of right now is that we know these drugs are effective, and these drugs can potentially be very beneficial, especially in areas where patients cannot get some of these more advanced treatments, such as CAR T. But because of some of the side effects and some of the logistical hurdles that are needed to safely administer these drugs to patients, there's been a little bit slower adoption of these medications in community settings, and most of these are still given in academic hospitals. I do anticipate as we move forward that these drugs will move into the outpatient setting in the community centers as they get more and more accustomed to the side effects, and we can develop better methods of predicting who will have some of these side effects, such as CRS, and who will have a higher risk for higher grade CRS, which will require hospitalization versus those that can be managed as an outpatient.